Okay, so we're starting with a really short, fast case. The chief complaint is I'm having a panic attack. It's a 35-year-old female with a history of anxiety, as far as we know, presenting with shortness of breath and feelings of anxiety. She reports she's going to court in 3 days to address custody of her children. She started feeling anxious on waking this morning, and it's been progressing throughout the day. The reason she actually came to the ER is because she was feeling hot flashes, her heart is racing, she's occasionally seeing things that she knows aren't quite there, describes them as shadows melting in the corner, and specifically keeps saying that she feels like the universe is dissipating away. Otherwise, she seems to be alert and oriented. Her social history, she drinks about half a bottle to 1 bottle of red wine per night, per her. History of untreated anxiety and surgical histories. Specifically, you'll notice some vital sign abnormalities. She's a little, it's true. Triggers the sepsis code. She's a little hypertensive with no history of hypertension. Tachycardic. Her temp is a little high. She's tremulous. She has some tongue fasciculations if you do ask her to stick out her tongue, which I don't know if I would have with this patient on the first time I examined her. She's tachypnic, but she has good air movement and she's clear to auscultation. No other signs of respiratory distress. She's tachycardic. She has some tremors in the upper extremities when her hands stretch out. And she is endorsing some visual hallucinations, but so far she's alert and oriented ×3, and she has good insight. She knows that the things she's seeing are probably not there. You ask her when her last drink was, and she says 2 days ago because she's going to court soon and she was trying to turn her life around. So delirium tremens is the topic of my presentation. Specifically, you're more likely to experience DTs if you have a history of withdrawal that needed to be treated, and also a history of withdrawal seizures. Timing starts within 2 to 4 days of your last drink, can last up to 8 days though. The vital sign abnormalities you're expecting to see are hypertension, tachycardia, and elevated temp. You'll see some auditory and or visual hallucinations, confusion, varying levels of alertness. On physical exam, it'll look like alcohol withdrawal, and symptoms that they'll be complaining of: anxiety, some GI upset, nausea, vomiting. Basically, DTs are withdrawal symptoms plus autonomic instability and a change in alertness. The prognosis with treatment is less than 5% mortality, typically from rhabdo or from arrhythmias. Without treatment, it's 5 to 15%. I didn't find any better numbers on that, typically from the same thing. This is a little bit of a busy slide, but this is the treatment option that historically most people go to, I think, from what I can tell from listening to different practitioners. They'll start with Diazepam IV. They'll start with lower doses, 5 Q10, Q5 to 10 minutes, then they'll double it to 10. End up with some people, like on MCRIT, they'll say that they'll try to give 200 milligrams in the first hour. Other people will give up to 400 in 2 hours. And then what the slide is saying is after 200 milligrams in the first hour, if your patient is still agitated at that point, you have a kind of decision tree. You can start getting ready to intubate, or you can reach for the Phenobarbital. If you're going for Phenobarbital IV push, you do it Q15. You start with 65, double to 130, then go to 260. At that point, if they're still having autonomic instability, then you're gonna intubate. So that's treatment option number 1. And that's based off of the study that's listed there. All the studies are in the end slide, whatever. Yeah, so that sounded like a lot of Valium to me because I'm 100% not comfortable with giving. Obviously, I wouldn't be. It would be an attending doing it. Just sounds like a lot. But it's important to remember that patients who are experiencing DTs are very treatment resistant to benzodiazepines. So you might give them really high doses and it won't even touch them. This one is starting to get more popular, Phenobarb monotherapy. You can start with a loading dose of ideal body weight, 10 mg per kg. It'll end up being about 700 for an average sized male. You wait 30 minutes for the onset, then you wait another 30 before deciding to go onward with the algorithm. Then you're doing 130 IV Q15 with a max of 30 mg per kg. There's a lot of great benefits to Phenobarb. There's a lower intubation rate. There's less of a sedation from it. I think in the study, the Ox et al. Study, 80% of the patients in this group did not have to be intubated, and the 20% that did had actually gotten some form of benzo prior to starting the Phenobarb. They had a mean ICU stay of about 5 days, which is lower than a bunch of the other treatment options that are listed that I'm going to go over. It's more predictable that with the pharmacokinetics, pharmacodynamics, you can actually measure the levels so to make sure that you're adequately treating them. There's a greater therapeutic index, and like we talked about, benzos can occasionally cause opposite of what we're trying to do. So, cautions, they work synergistically with benzos, so don't give a loading dose if you're previously already starting diazepam or Ativan or whatever. It's hepatically metabolized. Don't give it in cirrhosis. Some people have allergies to it. Usually, I guess if they're in DTs, you won't really find out until you give it, but if it's in the chart, don't give it. Treatment number 3, benzos and or Phenobarb with ketamine. There's 2 rates that I found that were studied. One of them was a very low dose. Apparently, that's not even enough to have any sedative activity. It's more of like a pain control. They did show a little bit of reduction in the rates of intubation and reduction in ICU stays and length of stays. But I also looked at the criticism of it, and it seems like there could have been a lot of confounding factors. The fact that when they started this protocol at the hospital, maybe less sick patients were then being given ketamine and put on ketamine drips and then sent to the ICU. So it was actually also studying less sick patients with DTs, which could have driven the length of stay in the ICU down. Otherwise, just having a new drug or a new study will bring more attention to DTs, and then you'll have a higher rate of diagnosing it, so catching it early and so on. There was another rate that was studied, 1.6 mg per kg per hour, which is a lot higher, probably has more of a sedative quality. This one's really hard to interpret because most of the patients in the study were already intubated, so it's hard to know what the intubation rate was. And then the ones that, I think there were 12 that got it that weren't intubated, and half of those had to be intubated. So not really sure what to take away from that. Basically, need more studies. Precedex. A lot of ICUs use Precedex. There's not great evidence for this either. Apparently, it does decrease mild alcohol withdrawal symptoms, which makes sense. It does work on autonomic instability, but if you think about the actual pathophysiology, it's not treating the alcohol withdrawal at the source. So do we really know that it's treating the DTs versus just masking the symptoms? I think most people think it's probably just masking the symptoms. It made the ICU stays a lot longer. They weren't able to be weaned off as quickly, and some of them still did have fatal dysrhythmias. So, yeah, so far, I would say no on the Precedex from what I've read. Goals of therapy, you're trying to get them to the RASS score of 0 to -1 and a heart rate of 110 or 120, depending on who you talk to. Basically, this means you want them sleepy but arousable with a heart rate of less than 110 or 120, depending on who you talk to. If you do intubate, there's some thought that rocuronium is better than sex. I think in general, most people have heard this. Supposedly, time to desaturation is shorter with succinylcholine. However, the first pass intubation isn't changed, and the actual rate of adverse events isn't different between the two. So what does that mean for realistically intubating? Probably nothing. Then you also start a propofol drip. Consider fentanyl versus ketamine for pain management. And that's it. Any questions? Yes.
Did you come? Me?
Yeah.
Did you come across anything about using GHB since our next presentation is on GHB?
I did not.
About using it as an adjunct because it's kind of. What? No, I was just curious. All right, just curious.
Yeah.
Just keep in mind, guys. Actually, in our ICUs, they at downstage 2, I believe, still and county, they can't give ketamine drips there. It's like a weird institutional thing. So if you start with ketamine, you won't be able to continue it. So normally I would say, okay, yeah, let's try this, but that's one that it's going to make it harder to manage the patient down.
Is actually to be able to add one patient on the first. Yes.
One other thing too, that we don't have any IV Valium.
Yeah, I was going to mention that there's no Valium in the Pyxis, so it's going to take a while to order it. We have it in the pharmacy, I think, now, right?
We have it back now.
Yeah, but we don't have it in the Pyxis.
I don't know if they replaced it yet because it had been in there. It should be in there, but we just recently, like 2 or 3 weeks ago, got our supply of IV Valium back. So I'm not sure if we've been it back in the business yet.
But if you're feeling really funky, you can start with Phenobarb monotherapy.
Yeah. Awesome.
All right, cool.
Thank you very much.